Hi, this is Dr. Arthur Zembowitz. Welcome to the next Dermpedia workshop. I'm here with Dr. Gerard Gardner, who's joining me from where? Where are you?
Danville, Pennsylvania.
Oh, from Pennsylvania. Probably most of you know him, especially from all of those who ever used the internet and typed in pathology or dermatopathology and counted on his content, which is all over the place, and it's very high quality. And I've always wanted to do workshop with Gerard because I thought this would be a very good combination, doing something together. He brings the expertise in soft tissue tumors, and he's one of those folks who are really very prominent in dermatopathology, all these alumni of Sharon Weiss. Is that correct? You must have been one of the last, maybe, or towards the
let's see. There were about 4, maybe 5 more people after me that trained before she retired. But a real great honor to get to work with her for a year. She was amazing.
So it's just something amazing about her. I never met her in person, but I think the impact she had, both in terms of her writings, but also the impact she had on people who, did fellowship with her and what they accomplished later on in their lives. I think that's amazing. I'm glad we are here together. You folks, you know what to do. I'm asking everybody to scan the QR code, which is here, to join the Mentimeter presentation, and I'm going to put the link to the Mentimeter presentation in chat for those of you who want to use your desktops. My recommendation always is to use the cell phone. It's more convenient. You can also go to www.menti.com and use the code that's on the screen to join the presentation. That's another way to do it. So let's start with a Mentimeter training question. So for you guys on the Mentimeter, tell me what best describes you. And you will have a slider, and you slide to the left if it's you, to the right if it's not you. Okay. Okay, and I give you 10 more seconds. And in the meantime, those of you who are still joining, here's the QR code to scan on your cell phone if you want to participate actively, and we'll be asking a lot of questions today. Okay, so that's here's our breakdown of the first Mentimeter question. So we usually have experienced people on these calls, and here is the second question. How many Dermpedia events, videos have you participated or watched so far? And I'm encouraging everybody to scan the QR code and join join actively. And I give you 10 more seconds.
Just for anyone out there who voted, I find squamous lesion. Don't find, if you find squamous lesions difficult, I still do. I've been in practice for 2 years.
Yeah, that's a leftover from
almost every day.
That's a leftover from last workshop that I did with Christina Ko from Yale.
Oh yeah, she's so great. I love Christine. She's amazing.
Yes, that was fun.
So yeah, you'd think it should be so bread and butter and easy, and yet here I am struggling over a decade into practice, and I'm sure I still will be at 2 decades.
Yeah. So welcome, especially for those for whom this is the first time. And here's the second next question: how many Dr. Gardner's events or videos have you participated in so far? And I expect that actually this will be a higher number. Let's see. And that's not a competition, it's just I was just curious.
I won't be offended if you all say 0. It's fine.
Huh? No. Oh, so you have more first timers.
Awesome.
And Well, that's a Dermpedia audience, so it's kind of a similar breakdown, I think.
Well, some people did over 100. Wow, you guys that's amazing. We got one person over 100.
Oh, yes.
Bravo. That's amazing.
Yes.
If you can tolerate me for that many videos, that's impressive.
No, we have quite a few. Yeah, and this estimate. So we certainly have overlapping audiences. That's for sure. So the next, it's time to do some work and look at some cases. And let me start. So just, why don't you start and tell us about this case, and we'll look at the slides.
All right. Yeah. So this was a young girl, 5 years old. She had a kind of slightly soft scalp mass present since birth, and clinically they thought it was a vascular lesion. I think they'd even, if I recall correctly, done ultrasound. It looked cystic and probably vascular. So I think just kind of because it was, it was noticeable, I think they decided to remove it, mainly for, cosmetic purposes or just so there wouldn't be a lump there anymore. And then we got the pathology results.
Okay.
The slides here.
So here is that excision. And there were actually two, I think, right? Or
there,
no?
I think this is just one. I
Just
think there
one.
must have been a little cut in the top of it. Like it opened up at some point during the operation, maybe that I don't think is a real ulcer. I think it was like kind of a defect, but it was a complete excision done by a pediatric surgeon, I believe, or plastics, one of those. And they, so they took it all the way down to the fat and kind of took it off the galea off the top.
So what I'm seeing, I see a lot of hemorrhage in the center, and I see those kind of like a spaces.
Yeah.
In the periphery, and so let's show it to the audience. So here's the higher magnification on those spaces that are lined by cells, and there's a blood inside. So I just want to show you kind of a sample of what might be. So that's the lesion.
Then at the periphery, you can see it kind of trickles out. It's not like very well circumscribed either towards the bottom or the sides. It kind of, trickles in between normal structures.
And that induces some vascular proliferation too, or maybe that's kind of something that looks like blood vessel. And here's the blood vessel that you mentioned, that it was apparently in the surgical report, there was a connection to a blood vessel.
That's right.
At least that was how it was reported. So let's ask the audience, do you have a diagnosis, even just based on what we've shown, which would not reflect probably the real life situation, but what are the considerations? So if you have those considerations, if you could write it on the Mentimeter. And in the meantime, I'll show a little bit more of that H&E. So we have a young child with those spaces filled with blood. Okay. So let's go back to the Mentimeter.
Those are all great ideas.
Yes, so that's, vascular malformation, the more responses are from the same
right.
same
They get larger if
they get larger.
more people vote for it.
Yes. So, okay. I think that may be enough for this. And now the question for you is, which of the following stains would you like to order? Are there any other considerations that you might have? And this should be a quickie. I'll give you 20 seconds to respond. Okay. So, vascular markers, a few votes for EMA, CD34, keratins, and some other options were selected. So let's take a look at some of those. D240, stain. So Jared, narrate and walk me through this one.
Yeah. So do you want me to talk about like what I was thinking and how I was approaching this?
No,
And then
let's
I don't
just
want
analyze
to.
the slide and then
Yeah. So I mean, here's D240
just
and
report, and then we'll have a discussion because we're going to
beautifully
ask the
positive,
audience.
right?
It's
Around most of
positive.
these.
Yeah,
Yeah.
yeah,
Very nice staining.
very
As
crisp,
control,
positive.
you can look up and see there's lymphatics in the dermis. It also stains some of the outer root sheath cells. So it's always nice to know what internal controls will light up,
So all the spaces
And,
are positive for
yeah, pretty
D240.
much.
Okay. Another ERG, it was popular. And here it is. And that ERG looks negative. Ouch.
Yeah, dead negative.
That negative. And the next.
And I also did 34 and 31, and 34 was cleanly negative. And 31, there was like a little bit of wishy-washy staining here and there, probably histiocytes, but mostly negative.
Yeah.
So
And you thought of something, and you are like a few members of the audience, you did EMA that you chose to share. And let's show what this one showed.
and look, just as a little bonus, look at how tiny those sebaceous glands are because she's a kid, right? The sebaceous glands are so little in children and very immature until puberty, right? When they get androgen, response and they get larger. So that's kind of cute. And it's a nice internal control. And yeah, look at that EMA. It's not diffusely positive, but certainly there are areas that are strongly positive, especially towards the deep aspect of the lesion. And over towards, I think, the left side of the slide a little at the bottom, there's an area kind of by that sclerotic zone. There's a little area where you can see kind of some slightly round kind of world structures that are EMA positive. It's pretty nice.
Yeah, so it is positive. So now, what is your diagnosis? That's a question for the audience. And 5-year-old scalp lesion.
Yeah, I love this case too. Whoever gave that heart, this is like a really, really awesome case. I'm easily excited about cases. And one of my former fellows, who's now my partner, Michelle Pitch, she always she accuses me of saying every case that I'm like, this is the best ever. And it's true. I say this is the best ever all the time. So we have a joke. She'll be like, is it TBE? Is it the best ever? And I'm like, let me show you. And she's like, okay, that is the best ever.
Oh, you're an
So I like that
extrovert.
she kind of pokes fun at me,
Yeah.
but she's totally right. I'm easily excited, but this case is the best ever.
Yeah,
Okay.
that's what Dr. Mim he was like, because I was very lucky to work with him for 10 years. So,
Oh, that's so
and he was
cool.
always 100% on. There
That's
was just
awesome.
nothing in between.
I'm so glad I got the chance to meet him at a meeting at USCAP one year. I got to meet him and went up and shook his hand, said hi, and I'm so happy that I had that experience. But
Yeah.
I've heard just so many great things about him.
Yeah. So there are, there's like a competition between, hemangioma and meningioma, in lymphangioma, and you did a few additional stains that included those, and so now would be a good time to say what was your thought process,
Yeah, so
and how did
I'm
you
with
arrive
all
at
of
the
Andy.
diagnosis? And your diagnosis was
Yeah,
meningothelial
this is a
hamartoma.
meningothelial hamartoma, which some people also use the term ectopic meningioma or cutaneous meningioma. Although it's really probably in this context in kids, when it's congenital, it's not neoplastic, actually. It's probably kind of a malformed hamartomatous process, maybe a bit that got left behind embryologically, which I think fits with that idea that they had that kind of cord. They thought it was a vessel surgically, but I think it was kind of a tether of a little bit of tissue that connected probably originally to the dura, you know? And since there was no defect in the skull, I wouldn't call this like a meningomyelocele or a meningocele, anything like that. But it's kind of, you could think of it as being within that same spectrum, I guess. So yeah, so what and some people have called these, I think when they call them cutaneous meningiomas, people have divided them into 3 subtypes. Type 1, which I believe is like this form, which is really a hamartoma. And then there are actual meningiomas like neoplastic that can arise outside of the skull or that can grow through the skull. Pretty rare, but I have seen that happen before. So in this case, it looks like a vascular lesion, right? So the problem, in fact, one of my partners got the case first and they brought it to me and they said, I think it's a hemangioma, but I'm not exactly sure is there a special name for it. And so that was my problem. And that was the first clue that this was something weird, was it looks vascular, but it doesn't fit neatly into a box. For a 5-year-old kid, there's not a I was thinking, what are the options we have? Well, there's infantile hemangioma, right? The kind that babies get, the strawberry hemangiomas that kind of regress over time. Those look very different from this, right? They have little tiny vessels packed really closely together. They're very cellular. The old name for those was cellular cellular hemangioma of infancy. So this is definitely not that. It doesn't, and if you did GLUT, guess what? GLUT 1 would be positive here probably. And I would normally have done it, but we happen to have been out of GLUT and we're waiting. It's on back order. We're waiting for a new stain when this was happening. So that's why I didn't have a GLUT for you here. But normally GLUT 1 would be a nice stain for this too. So that could confuse you. If you did GLUT, you would say, oh, it's infantile hemangioma. But in fact, meningothelial cells are GLUT 1 positive too, just like perineurial cells are. So I looked at it and I thought, well, it's not infantile hemangioma. Then could it be rich or niche, like congenital hemangiomas, the rapid involuted kind and the non-involuting? The rapid involuting kind would be gone by 5 years old mostly, and so that wouldn't fit. And then the non-involuting kind, the ones I've seen, they're much more well-formed channels. This is actually pretty infiltrative if you think about it. Look what it's doing. It's individual cells that look kind of like endothelial cells wrapping around individual discrete dermal collagen bundles, wrapping around normal vessels, almost like the promontory sign of Kaposi sarcoma. In fact, I actually even did an HHV8 stain here just to be totally safe, because there are like lymphangioma-like and cystic kind of variants of Kaposi. I've never encountered one in practice, but I've seen them in study sets. So it would be really, really rare for a 5-year-old to have Kaposi sarcoma. But I thought, let's just be totally sure. So the best thought I had was that maybe this is either a weird vascular malformation or a lymphatic malformation, like a so-called lymphangioma, because sometimes malformations can get pretty infiltrative and kind of mimic that growth pattern of Kaposi or angiosarcoma. Clearly in the scalp of a 5-year-old, there's just no way this could be an angiosarcoma. It's exquisitely rare for angiosarcoma to be in kids. I've never seen a case in a child. And if they were, I mean, there's no atypia here. It's very bland. So as I looked around, I also thought about, there is this thing called meningothelial hamartoma, and they look kind of lymphangioma-like or vascular. They have cystic spaces. They don't really look at all like the actual tumor meningioma. And as I looked around and thought about that, I encountered a few psammoma bodies, which Dr. Zembowicz just showed down there. There are a few psammomatous calcifications at the base of the lesion right there. And there's also a few areas where the cells are a little more round and they're kind of vaguely whirling and swirling within this dense collagen stroma, kind of like the whirling and swirling you would see in a meningioma or a perineurioma. So my initial round of stains, I think I did D240, CD34, CD31. And I usually like to do ERG, but for some reason I forgot to order ERG. So D240 came back beautifully positive. And I forgot about the fact that, guess what? Meningothelial cells and meningiomas are usually D240 positive. So that's another trick. So once I did the ERG was completely negative, and so was CD34, and 31 was mostly negative. So ERG, in my hands, in my experience, is 100% sensitive for vascular and lymphatic tumors and proliferations. Now, no stain's perfect. I'm sure if I do this long enough, eventually I'll be proven wrong. But basically, if it's ERG negative, the chance of it being a vascular or lymphatic proliferation is close to 0. I'll say that. In my experience, I've never yet seen a vascular lesion or lymphatic lesion that's negative for ERG. It's not a specific marker, but it's very sensitive. So the fact that this was totally negative for ERG basically takes lymphangioma, lymphatic malformation, vascular malformation, all of that out. And then I had the thought of like, well, what things could I do if I really want to prove these are meningothelial cells? And I had to do a little bit more searching to find out, what other things stain meningothelial cells but wouldn't stain vascular. And that's when I had discovered another thing that was positive is ecadherin. I found a paper that it was talking about meningiomas are often positive both for D240 and for ecadherin. And I don't have the slide, I didn't upload it. These are pretty big files, and I didn't want to upload a million of them. So I did that, and I did a couple other markers. PR, progesterone receptor, which is positive in meningiomas, but I wasn't sure how much staining it would have in like normal meningothelial cells. It was kind of patchy focal positive for PR. A decent bit of SSTR2, which is somatostatin receptor 2. That's a positive marker in meningothelial cells and meningioma. And then ecadherin was nicely positive. So all of those things together supported that this was meningothelial origin. I didn't find any glial tissue. In fact, I think I even did a GFAP on one block to make
Wow.
sure there was no glial stuff
So
in there. 'Cause
there's
I thought,
no chance whatsoever. This is
yeah,
probably the most worked up
yeah.
ectopic meningothelial
And
hematoma
admittedly,
on
I
this
did a few of the
planet.
states for teaching because it's just such a nice example.
No,
But I thought it was very lovely. And
yes.
and when I was looking back in the literature, back in the 1990s, when this was originally described, it was noted that these tumors can have a growth pattern that mimics angiosarcoma. And of course, in a
Yeah.
5-year-old, you wouldn't really be worried about that. But some of the cases originally described were congenital lesions, but that were present until adulthood. And so they were removed in adults. And then you could that kind of growth pattern, if this was an old sun damaged person, I'd be worried about angiosarcoma, even though there's no atypia. It would concern me, to see it grow like that. So,
Yeah.
such a cool, amazing
Yeah.
case. And someone said, why not an atretic meningocele? I think arguably you could make the argument that maybe these exist on a spectrum with that. I mean,
This is a clinical pathological entity. For me, the nuclei. I mean, you just want to see this nuclei. These are meningothelial, very fine kind of salt and pepper type of nuclei.
yeah.
They're very characteristic for this entity. And actually, pediatric dermatologists are very familiar with this entity clinically because they present as a bald patch, and then the differential of a bald patch in a child is very narrow, and here the hairs, they stick out like around this kind of almost like horizontally. There's like a corona, so there's very characteristic clinical appearance
Yeah,
of these
unfortunately, there
lesions.
was no clinical photograph for this. I
Yes,
really
yes.
wish there would have been. That would have been cool.
Yeah,
Um,
wonderful. I think
really nice.
that's a
And it's such a big one. I've only seen this one other time in my career. It was, I think, on the nose of like a
mhm,
10-year-old, and it was really tiny. I think it was on the nose, which
yeah,
was kind of weird, I thought. But it was a really small lesion, the only other
mhm,
one I've seen. So this is a really nice, beautiful
yeah.
example.
Wonderful. That's really great. Let's see if there are any questions.
Thank you, whoever
Yeah.
said I had Madhu Dewan. You come up with nice cases. I try my best. The cases just find me, is what it seems like.
Yeah, it's really great. You have a different style and different. I'm intrigued by controversies and by things that are kind of not clear cut, and that's a lot of content that I share, which is good for experienced people, like on different perspectives. And but you have this knack of describing this, lesions and all this differential
Yeah.
diagnosis and
My favorite
literature.
thing is
It's
like the rare, really perfect example. I love
yes, that's
those. And the controversy I find is like it is interesting, but it's also challenging
to
and I
present.
don't always
Yes.
know exactly the right answer. And I kind of
Yes.
shy away sometimes from making videos about that stuff because it's a lot harder and more difficult to make a video
Yes,
about.
yes.
It requires much more prepreparation. So kudos to you, Artur, for
Okay.
doing.
Well, it's more of our personality and kind of what drives us. But that's really fantastic piece of education. Actually,
Yeah, I
wonderful.
learned a lot from that case because I had to like
Yeah,
delve into like thinking about stain. I don't think about meningothelial stains very often, and it
yeah.
was really fun to do a little searching on that.
Okay, wonderful. Case two, 23-year-old female. And any story at this point? And we're going to show the H&E erythematous plaque on the lower
Yeah, I can't
leg.
remember how they said there was a clinical photo, but no one ever sent it to me, and it was an outside consult case in the past. I try not to take consults anymore because I like to go home and see my family, um, but yeah, they just said it was a kind of a reddish, reddish plaque on the leg of a young woman. I think it had been there for a few years, slowly growing,
Hmm.
if I recall.
So, that's kind of a busy
Hmm.
case, busy lesion, busy tumor, nothing in the dermis, yeah. And kind of
This
looks
one
looks
really,
vascular, doesn't it?
yes, it does. This one really gave me a hard time, and we
Oh
finally figured
gosh.
it out with the help of a fellow, actually.
Yeah, let's kind of digest it. Let's present it, and it kind of goes deep into subcutaneous tissue. A little bit patchy inflammation. Kind of bland nuclei, but kind of
Agreed.
bubbly. Hmm. And here we're infiltrating fat. The tumor infiltrates the fat. Again, it has those nuclear bubbles. Kind of, okay. So that might be it for H&E to get us started. Very infiltrating in the periphery. And then we're going to show some H&E, actually immunohistochemical stains before we ask about the diagnosis, because I'm sure all of us would have a panel to assess a lesion like that. And let's look at those three that you picked to share. CD34. It looked positive as the vascular lesion would, but are the vessels that are staining or?
Yeah, and I did a 30, there was a 31 also, but unfortunately the slide was, it came with the case, it was broken, and so I wasn't able to get a scan of it because of that. And it was
Well,
very
it is
pretty though.
positive, right? There's
Mhm,
no,
yeah.
yeah, I mean, there's no
Yeah,
debate.
31 was like this similar pattern, but a little cleaner looking, as is usually the case with 31.
Smooth muscle actin. Let's look at that one. So we see vessels, but fewer vessels or vascular structures than on H&E that are positive, right?
Right.
There's some cellularity in between those vessels. Let's go into the subcutaneous tissue where that infiltration occurred. So these are nuclei of those cells that so we will have to come back to the H&E. And then you also was kind to share the S100 stain. And
This one I did not do at first. This was a kind of afterthought that came later. Once I thought about things a little more and had some extra.
once you had a dead alley.
Yes.
So it's positive, right? So there's a staining, and those cells look kind of more kind of dendritic in a way. So let's take a look at the H&E. One more look, and then we'll be, I think, at the Mentimeter soliciting suggestions about this lesion. And here, actually, before that, I added one more thing for you to consider. How about a blend, because we have a blend spindle cell tumor with expression of CD34 and S100, but negative for SOX10. We don't have that stain, but I added it. And now, what is your diagnosis? So Gerard, what else would you tell us kind of about your process as people are on the Mentimeter typing in?
Well, I
It's
don't.
this vascular analogy, I think that is something kind of,
Yeah, so
if
and
this was
I
vascular
tried,
lesion,
I
what
had
would that
trouble
be?
with I ran out of time. There are a couple of H&Es on this excision,
Uh-huh.
and one of the other ones really looked very much vascular, like the dermal component. And the sub-Q part was only on this slide. So I wanted the other slide was actually what I looked at first, that just had these really prominent kind of infiltrative but bland, thin, compressed dermal vessels that trickle between the collagen bundles, you know? So when you see that, when you see, you know, thin but well-formed, bland vessels that trickle between collagen, you know, that reminds me of something. I've not seen anyone type it out yet. So see, I think maybe I just made a diagnostic, an initial error, and I couldn't let go of it, which is kind of the point of why I wanted to share this case. It's an interesting and kind of uncommon thing, but also it was an example of like how I made a mistake at first, and it caused me trouble because of that mistake. So
yeah. So let's see what people.
yeah,
Some
let's see what you guys
suggestions.
think, and then I'll tell you what I was thinking. Yes, that's exactly what I thought, and thank you. You all made me feel better. My first thought was, this looks like a microvenular hemangioma,
Yes.
kind of, but it's weird. It's not quite right. It's so big, it's so deep. There's all these extra cells in between, like that look like histiocytes. It's going into the fat. What in there? Lymphocytes scattered in there. What is going on? Like, I've never seen, now I've not seen that many microvenular hemangiomas. They're, in my hands, at least, or in my experience, pretty uncommon. I've seen, I don't know, a handful of them in my career. So I thought that's the closest thing I could fit it to. But I was like, but it's not right. So kind of like the first case, looks maybe like a weird vascular thing, but it doesn't fit neatly into a box. And, you know, sometimes things are like that. They don't fit into a box. So my main question then is this something that is a normal a described entity that's just a weird variation of it that I've not seen before, a different flavor of a known entity? Or is this some unclassifiable unknown entity, you know, that just has not been reported yet? Or is this something else and I'm being tricked? And in this case, it was something else and I'm being tricked. So I thought this is probably weird microvenular hemangioma. The outside pathologist had thought the same thing. And I looked at their workup, and before I saw that's what they thought, I thought the same thing. I kind of came to the same conclusion as them. But like them, they said, but it's kind of weird because of how deep it is, how infiltrative, how cellular. And I felt the same exact concern. Like, it's not quite right. It looked benign, but I generally, I prefer, if possible, when I have a weird, a tumor that looks benign, I like to have a name for it if possible. And that's because one of the lessons my mentor, Jay Rowe, at Houston Methodist Hospital, who passed away a couple years ago, but really one of my greatest mentors, the reason more than anyone else that I became an educator is because of Dr. Rowe. And Dr. Rowe always said, if there is a tumor that's a neoplasm that looks benign, but you don't have a name for it, you don't know what it is, don't just call it benign neoplasm NOS, unless you're an expert in the field or you show an expert. And I think that's good advice, because that's the way you make mistakes, right? Think about DFSP or a lot of other soft tissue tumors. They don't really cytologically look malignant, right? Many of the translocation sarcomas don't look malignant. And yet they're malignant because of the pattern. So that's the kind of thing, if you don't know about that pattern, you can get into trouble. And I don't know, I guess I'm maybe approaching expert level, but I still don't feel. Dr. Weiss told me, referring back to Sharon Weiss, she said, Jared, do you know what the definition of an expert is? And we talked a lot about other things besides pathology. And, you know, some people say an expert, someone with 10,000 hours of experience, which I think I've got my 10,000 hours now. But I love the practical way she said, Jared, an expert is someone who can look at the slide and instantly know whether or not they will be able to solve the case. And I love that. And Dr. Weiss could do that. You know, she would either know this is something unclassifiable, or this is X, Y, or Z, and I know what stain or what workup to do to get there. I still don't have that complete confidence. I'm always like, this must be a thing, and I just don't know what it is. And then I'll send it to an outside expert, and they'll be like, yeah, we're not sure what it is either. And that makes me feel better, but it also is unsatisfying. I want the answer, right? So I still don't have that total confidence that I'm not missing something. So anyway,
So another, let me interject. Another definition
yeah.
of expert is access to microphone. In some circles, that's what counts.
True. Whoever's the loudest voice is the expert, right?
Access to microphone. So here's the question: which molecular test would you like to perform?
And I saw some people on there thought of it. Very good.
Yeah. So let me give you 20 seconds.
So the thing is Dr. Zembowicz helps us here by showing the S100 and bringing up that really great point of co-expression of 34 and S100 without SOX10 expression. That is a distinct and unusual combo of stains that right away should make you think of what you guys thought of, an NTRK NTRK-rearranged neoplasm. But that was not on my radar at all. And I do know a little bit about that tumor. I've actually diagnosed it before multiple times. I've made a video about it before. It did not occur to me here at all. And I'll tell you what really helped. It was humbling and also awesome. I hope she doesn't mind, but I'm going to call her out by name. I had a visiting fellow from Penn State Hershey, Dr. Sydney Hoskins, who was working with me for a week because they don't have as much soft tissue at Hershey. So she came and visited for a week and spent time with me. And I was showing her and said, oh, this is a weird vascular lesion. And you know, I think it's kind of like microvenular hemangioma, but it's not quite right. And she was like, well, I didn't really realize that it was a vascular lesion at first. I thought it was some other spindle cell lesion that just had vessels. And it was really that like fresh set of eyes that was so helpful because I was like, you know, maybe it's not a vascular lesion. And the more I looked at it, the more I realized there are areas with lots of extra cells. And maybe that's the reason there's extra cells in between the vessels, is because those cells are actually the lesional cell and the vessels are just like a bonus, right? They're just a really rich vascular network. And there's a tendency sometimes for pathologists to fixate on vessels and think something's a vascular tumor when it's not. And I often like to teach about that. And I fell right into that trap. And this is a good example of like anchoring bias, right? I thought of microvenular hemangioma and I couldn't let it go. And so I ended up doing an NGS fusion panel on this. And I even felt kind of silly doing it because the outside pathologist was like, well, could this be a hemangioendothelioma or something? And I was like, no, it doesn't fit into any of the hemangioendothelioma categories. And you can't just call stuff hemangioendothelioma NOS or else you're just making it a wastebasket. But the reason I did the panel is I thought, I don't know exactly what this is. I want to make sure there's not something else I'm not thinking of. And it was a big excision they did, but it was still positive at the margins. So the question was going to be, do they need to excise it more or not? And even though I thought it was benign, I didn't have a great name. And I'm so thankful I did that panel because it came back with an NTRK-3 fusion. And it was while we were waiting for that I shared the case with Dr. Hoskins, and she said, you know, I didn't really think it was vascular at first glance, and she was totally right. And that's when I thought, after I did the S100 later, and it was positive, and I was like, oh, it is going to be an NTRK fused neoplasm, and that's what the molecular came back as.
Yeah.
So
Wonderful.
these are a new emerging class of tumors. NTRK fusions are in a lot of different things, right? We know spitzoid lesions can have them. Infantile fibrosarcoma, which is a really rare soft tissue tumor in babies. And then this nebulous group of NTRK-rearranged mesenchymal neoplasms. So I imagine this, because it's an emerging thing, over time, the new WHOs will probably eventually parse this out into more than one thing, I suspect, because the question is, well, what are they? What do they do? Well, it's not really clear. What the WHO currently says is basic, when we're asking about behavior of these, if they look benign, they will probably have indolent benign behavior. If they look malignant and have an NTRK fusion, they'll probably behave like a sarcoma. So it's maybe not exactly one lesion, but kind of a group of mesenchymal tumors that have NTRK fusions that have a variety of different behaviors depending on how the individual case looks. And they have a wide range of morphologic features. So I have another case on my Kiko, in my Kiko Mega Index for soft tissue. If you go look up NTRK, there's a case I presented in France a few years ago at the IAP meeting. And it had, in the same tumor, had areas that looked like DFSP, areas that looked like dermatofibroma, areas that infiltrated fat, areas that had fascicles, areas that were bland, areas that had pleomorphism, all in the same tumor. And it co-expressed CD34 and S100. So yeah, weird spindly tumor that you can't quite put into a box. Keep this one in mind because it can really have a range of features and can mimic a lot of other stuff. So some of these originally were called like lymphofibromatosis, like neural neoplasm, but then people realized they were S100 negative, so they weren't really neural. They can look kind of like neurofibroma sometimes. This case did not. I'd never seen one with such a robust, rich vascular network as this case, and it really tricked me. But if you look in the subcutaneous, you can tell that's not a vascular lesion there, right? There really are more spindle cells, but I just couldn't let go of how my initial impression was microvenular hemangioma. So it was a nice thing. And someone asked about PanTrek. I don't have the PanTrek stain in my lab. And from my reading about PanTrek, it's a stain that can work, but it's a lot of times if you do PanTrek, you still often end up needing to follow up with molecular because it doesn't identify all TRK fusions. And then and it can sometimes stain things that are not actually rearranged. So it's a kind of a, some of these immunostains that are surrogates for molecular are really, really good and very specific, and some are not. And my reading about PanTrek has been that it's it's not as good as some of the other ones, at least. So I think it's probably helpful for screening if you have it, but I don't have it available to me currently.
Um,
So I just went to the molecular because
One
we do.
point I would make is just looking at this H&E is there's certain monotony
Mm-hmm.
of the cells, and that is always a kind of a clue about possible fusion associated
Absolutely.
neoplasm, in any context, melanocytic, soft tissue,
That's right.
and just a clue. And I'm very fortunate that I have access to NGS, and I usually just go to NGS in any soft
Yeah,
tissue
I love
tumor
it. The
that I
more I've used it, the more I'm finding stuff, and it's
that,
helped
that I
me
done.
quite a
Yes,
few times.
yes,
So in this case, let me think. I can't
yeah,
remember. I think I copied my report the other day and see. I'm trying to think. What did I tell them
yeah. I
to
think we
do? I
should go.
think
We
I
should we
said that
should
they
we
can
should move
watch
on.
and wait.
Jared.
Yeah,
I think
yeah, no
we
problem.
the next case. Actually, a little plug for the upcoming Dermpedia course, which is going to be held in April 15th through 17th, and change from the last couple of years where we were only virtual. It's going to be an in-person component in Boston. So you want to come to Boston, have some nice um, experience Boston. And this is actually a very good time because next weekend that's when the Boston Marathon uh,
Hmm.
is, and this is also the weekend when we celebrate, the first battle of the American Revolution in Lexington. So if you want to go to see a reenactment
Fun.
of Battle of Lexington on Concord
And
on
what a
Saturday,
stellar lineup of speakers too.
yes, yes, it's going to be great. And we will be, talking about interface of the subjects kind of between dermatopathology and general surgical pathology, including like mucosal pathology, ophthalmic pathology, GYN, pathology, lymphomas, some melanocytic lesions and squamous lesions. So it's going to be
That sounds awesome.
good. Okay, next case. Case number 3, 67-year-old Jared. Why don't you take over?
All right. Yeah. So this was an older adult woman, and she had a mass on the foot that podiatry removed by excising. MRI had been done ahead of time and found that it was well circumscribed in the forefoot, about 2.5 centimeters, and between the first and second metatarsal head. So podiatry did a complete excision, and it was sent to pathology.
Okay. Hmm. Very kind of a circumscribed lesion with a huge, like a capsule, looks like, or a lot of pigment.
So much.
Kind of a little pixelating a little bit slowly, or maybe it's out of focus skin. Maybe skin is out of focus, or it's
I
pixelation
think it was in focus. It must just be loading
loading. Yeah.
because I checked it ahead of time, and so it
Mhm.
should come in.
Let me see if there's another slide. Let's see how that one loads. It looks like the website is a little bit on the slow side here. Oh, here we go. I think we're just starting getting a sense of cytology. It's always hard to see cytology in the context of hemosiderin, and because then nuclei from the tumor, the nuclei from the macrophages.
Yeah, agree. And especially on that other slide, at first, everything you see is just pigment and fibrosis and reactive change and
This
a big
one, yeah,
cystic blood-filled and fibrin-filled space.
yeah,
Um, so a slide like this, my initial impression might be a little different than, and it was once I saw the next slide, that one that Artur showed first, that I was like, oh, wait a second.
yeah. It's kind of interesting low power, right? The cystic, hemorrhagic.
Does anyone know what the yellow stuff is? It's not ink. There's brown kind of granular pigment in there, but there's also bright yellow stuff being deposited in the tissue.
Hmm.
Very good.
What?
Hematoidin, something we don't see very often in Dermpath, because hematoidin. So I had to look it up again because I always forget the mechanism behind it. But it's what happens when blood, when heme breaks down in low oxygen environments. So I actually found a paper. I was trying to remember what the pathway. It's that erythrocytes break down and porphyrins are released from hemoglobin, and then those convert to biliverdin, which becomes crystalline hematoidin. So they make like these little crystals. Sometimes they even polarize, sometimes they don't, I've found. But I see it in deep soft tissue more and rarely in skin because you just don't often get blood-filled pockets in the skin that are low oxygen, you know? But I see it like in seroma cavities, old hematomas. And here there's clearly been a lot of bleeding, right?
Yeah. So you offered additional information that this lesion was positive for desmin, so the cellular areas, EMA, a few cells, and ALK1. And then the next step is a question about your diagnosis. Yeah, so let's see what people think while I'm still showing more of that lesion. That's inflammation at the periphery. Yeah.
Indeed. Lymphocytes and plasma cells, mostly, if I recall.
Yeah. Yeah, that's exactly what it is. So let's go back to the Mentimeter and load maybe 10 seconds. To see what people think. So it looks like people like Angiomatoid fibrous histiocytoma for the diagnosis. And you had information about the NGS. And so we don't have to run it again because it looks like people got it on H&E, right?
Very nice.
Angiomatoid fibrous histiocytoma. Yes, so
this is a tumor I've been fascinated with for a long time because it's just so weird. It's like sheets of these histiocytoid cells, usually with a blood-filled cystic space in the middle, and then usually with the peripheral pseudocapsule and a variable amount of inflammation, lymphocytes and plasma cells usually. Sometimes the inflammation can be so rich that it looks like a lymph node with a nodule of syncytial tumor in the middle of it. So I've got an example of that on Kiko, a really nice one that mimics a lymph node. So this case is weird for several reasons, okay? So this is a tumor that's good to know about because it's so weird and it can look kind of different every time you see it. Each one I've seen has like a little bit of a different flavor, but the blood can confuse you because when there's a lot of blood and when there's pigment, you can get thinking about other things, reactive things, old hematoma. So here I even wondered at first, on the first slide, I thought, could this be an old hematoma? And I saw the hemosiderin and hematoidin, but then I saw that big sheet-like cellular area in the middle, and I thought, I've seen a lot of organized thrombi and blood and fibrin, but I've never seen that much cellularity. And there are some scattered pleomorphic cells in the midst of that. So I thought, there's no way this can be an organized thrombus here. So I've seen a fair number of angiomatoid FH in my career. I've never seen one with this much hemosiderin. And this is also the oldest patient I have ever seen it in. This is usually a tumor of childhood. And occasionally I've seen it in young adults, people in their 20s or maybe 30s. 67 is definitely the oldest I've ever seen. So in the olden days, this was called angiomatoid malignant fibrous histiocytoma. It was thought to be a sarcoma. But then over time, people realized that these did not behave aggressively like sarcomas do. They do have the ability in a subset of cases to metastasize to regional lymph nodes, so they can recur locally. They can sometimes give regional lymph node mets, and more aggressive disease like distant mets or death from disease is extremely rare. I think maybe there's been, if I recall, last time I checked, one report of a distant met that was fatal ever in this tumor. So in general, when I sign these out, I say that these are a tumor of intermediate malignant potential, basically, occasionally metastasizing, but but rarely distantly. And I make a comment that more aggressive behavior is extremely rare. So they should be excised with negative margins. This case, it was narrowly negative, and I thought it was probably reasonable to follow up this patient, if I recall.
Yeah.
The other thing that's unusual about this tumor is it has a translocation, but it has 3 different translocations it can have. The most common one is EWSR1 fusion with CREB1. And then then the other 2 fusions are EWSR1 ATF1 or FUS ATF1. And the weird and interesting thing that when I first learned about this in fellowship that blew my mind was EWSR1 ATF1. What is that also positive in? A totally different tumor that looks and stains and behaves 100% differently from this tumor here. Does anyone know? What else has EWSR1 ATF1?
Okay.
You can type it in the chat if you know it. It's clear cell sarcoma, yeah, which was in the past known as melanoma of soft parts, which stains and looks a lot like a melanoma and is kind of aggressive, is quite aggressive actually. So that blew my mind in fellowship. Now that we know a lot more about molecular, it doesn't blow my mind as much anymore because we know lots of things have the same fusion in totally different tumors, right? We're seeing molecular answers some questions and then creates a whole bunch of new ones. So this is also a good exception. I love what Artur just said a minute ago about when you see monotonous nuclei, uniform nuclei, always think of a translocation tumor. Mark Edgar taught me that in fellowship, and I thought that was such a brilliant pearl. Most translocation-associated tumors are monotonous and uniform, but angiomatoid FH is a potential exception. There are some exceptions, and this is a most notable one. These, a fair number of them has scattered pleomorphism. And they can have a lot of rules that they break. And my friend Summer Bowman, who was a co-fellow with me at Emory when I was she was a surg path fellow when I was a soft tissue fellow. She went on to do her soft tissue training at Cleveland Clinic, and she and Steve Billings wrote a really nice paper about unusual exceptions to the rule in angiomatoid FH. It's a really excellent paper. I encourage you to read. It has lots of examples of times where angiomatoid FH doesn't follow the rules and doesn't look like it should. So this is easy to get mistaken because of the variability of its pattern. The other thing I always mention when I sign these out in a comment, because I've seen people get confused clinically about this, they think, oh, fibrous histiocytoma, so it's just like a dermatofibroma, right? So no, it's not the same thing. It's not at all related to benign fibrous histiocytoma, which is the same thing as dermatofibroma. So I make a comment that despite the name, this is totally unrelated to benign fibrous histiocytoma / dermatofibroma. It's totally unrelated. So anyway.
Okay, really let's move on to case number 3.
Those are the most esoteric ones. The other ones are a little bit more straightforward.
Yeah. And just talking about, you mentioned Steve Billings, so we did a Dermpath course 2 years ago, and it's available on demand, and we covered
Steve
that
is
topic.
An amazing dermpath and soft tissue pathologist. Really great.
Yeah, this was actually the best course ever on Dermpath. Really, it's such a great update for everybody. So the case number 4, young adult man with soft nodule on the trunk. And here is the H&E. Busy.
Yeah, quite.
In a routine practice, when I get a case like that, I don't like it. Because you just say, oh gosh, it's going to take
slow down the day, isn't it?
It's going to take time, or
absolutely.
But as a console, I enjoy them. Because that's different kind of a setting. But I hate if case like busy soft tissue case breaks my otherwise smooth sign out.
I know the older I get, the more I just want to see seborrheic keratoses and basal cells.
I love BCCs.
Finish it and go home. Yeah.
Yes. So yeah, it's kind of a and you did not provide any immunos for this, so we just trying to kind of get an idea of what the diagnosis might be on the H&E. Is there any particular area that you want me to?
If you go hold on, I can pull it up on my end. If you go to low power, I think it's maybe right down towards the bottom of that. Okay, first of all, see that little stripey area right under where your arrow is?
Right.
This is such a cool, it's like there's like tiger stripe kind of pattern. That's what I call it. I don't think that's a specific thing. I just thought it was so cool in this case that it's got these like rows of round cells, kind of like a round, looks like a round blue cell tumor almost, right? But the cells are very small and
On
very
here.
bland and not like hypercellular sheets or mitotically active, but they
Like
look so round, right?
little
Um,
rosettes or some kind of a
yeah,
cluster.
almost like little rosettes. There's some areas that are a little more spindly. Let me pull this up on my end and find. There is an area that has the diagnostic
Here's there's
clue.
more of that tiger
Yeah, and
pattern.
then very, really extensive fat trapping, right? Honeycomb, really, if you will.
Hmm.
So I see someone said, what about DFSP? So the thing about DFSP is usually it doesn't have round cells, right? It's usually thin, elongated spindle cells, not round blue looking cells like this. And myxoid liposarcoma, that's a really excellent idea too. They can have little rounded cells, not usually so cellular. They do in the more high grade form, or what used to be called round cell liposarcoma.
So guys,
And
on the Mentimeter, you can
oh yeah, sorry, I forgot
diagnose.
the
No,
voting. I'm
that's okay.
looking at the chat. Sorry,
No, that's okay.
got ahead of myself here.
You know, we have so yeah, I'm just going around, but I really we welcome your suggestions, and
Looking on my end
I'm
to see
going to
the.
load maybe
Oh,
20
there.
seconds.
When you pull it back up, I'll show you where the clue, the key to the
Okay,
diagnosis. Because I thought I knew where it was, and I just had to refresh my memory. It's been a little while since I looked.
okay, I'm back on the
So on the top piece, near the bottom, near that green ink, just right dead center of the screen, go in closer. Uh-huh. And then right along that ink there, scroll a little bit to your, let's see. I'm trying to match the piece there. Where are you? You're at. Oh yeah, go a little to your left, past that crevice. Keep going along until there's like a big pink bundle over to the. Keep going left. There's a big pink area
right
and a
there.
couple little blood vessels above it. Oh, right there. There you go. That's the key. So
Okay,
now the diagnosis.
so
Oh,
let's see
sickle
what
cell
people.
lipoma is a great idea. Great
So
idea.
people thought you guys didn't do that great.
It's a hard case.
It's a hard case. Yeah. So yeah, it's a hard case. So yeah. So what you're gonna dissect it for us?
So yeah, this is a case, and I had thankfully seen one. This is not the example that I saw in fellowship, but I saw one kind of like this in fellowship, and Dr. Weiss instantly recognized it and said, "Oh yes, this is diffuse neurofibroma." And I was like, "But it has round cells," and I'm so glad I saw that case because it's so different than the neurofibromas that we otherwise see. Right? This doesn't look at all like the cutaneous nodular neurofibromas or like the plexiform neurofibromas. So then Dr. Weiss said, oh, it's because diffuse neurofibromas, the Schwann cells are often more rounded and not as elongated as other forms of neurofibroma. And so sometimes they can have zones that look kind of like slightly cellular round blue cells, still very bland. And just like all neurofibromas, very rare mitoses. Mitoses are very infrequent in neurofibroma. And then when you look around, the fat trapping is not surprising at all. Diffuse neurofibromas usually entrap fat. And when you have a spindly diffuse neurofibroma, some diffuse neurofibromas are totally spindled and don't have any round cells like this. The round cell ones just are really weird and they confuse people, I think. They confused me when I first saw it. So the spindled ones, though, are another trap because they trap fat, they look a lot like DFSP. And guess what neurofibromas are positive for? CD34. So if you think DFSP and you do a CD34, you're going to get burned. So always remember in your differential, if you're thinking of DFSP, if there's any chance it could be diffuse neurofibroma, add an S100 or a SOX10 to make sure, and that will easily sort this out because that's going to always be positive in a neurofibroma, whereas CD34 will be positive both in DFSP and in diffuse neurofibromas. So the structure that we were showing you down at the bottom there near the ink, that's called a Wagner Meissner body. And those are basically the tumor recapitulating Meissner corpuscles that you see, the fine touch receptors, tactoid receptors in the the palmar and plantar aspect of your finger pads and toe pads. And they look like a little clustered aggregate of Meissner corpuscles there. And they are most commonly seen in diffuse neurofibromas. You don't always have them, but it's really nice. When you have them, boom, you got your answer. The other place you can see these much more often is in neurotized nevi, right? Neurotized nevi make a very similar structure that looks to me just like this. And some people call those meson bodies or tactoid bodies, but I basically think of them as just the nevus version of Wagner Meissner body, okay? So that's a really nice clue. And of course, if you did S100 here, it'd be positive. This patient had NF1. Okay. And so diffuse neurofibroma is the second most common type of neurofibroma in NF1 patients. You know, plexiform is the kind of sine qua non. You basically, that a diagnosis of plexiform NF, you are giving someone NF1. So don't ever make that diagnosis lightly. And then diffuse neurofibromas are very common in NF1 patients and sometimes coexist with plexiform. I've seen like plexiform neurofibroma with diffuse filling the space in between. But you can also get diffuse neurofibromas in sporadically in regular patients without NF1. If you see a diffuse neurofibromas that's really big and weird, though, that's the kind of time where I get a little more concerned and make sure that clinically they've done a good physical exam to make sure the patient doesn't have subtle NF1. Because not every NF1 patient is covered in neurofibromas. There's a variable penetrance, and sometimes people have deep plexiform NFs, and their skin looks basically normal, or they may have just a couple little neurofibromas or a few cafe au lait macules. So I've met patients like that where I was shocked. They're like, "Oh yeah, I have NF1," and I said, "What?" And they said, "Yeah, look, I've got a couple neurofibromas." And then they had a big deep plexiform one that had been diagnosed on imaging. So that was really mind blowing when I met a patient like that once a long time ago, and really opened my eyes that not all NF1 patients are like the books show. Spindle cell lipoma is a great possibility too. They can really look neural. And I always say, if you think you have a neural tumor, but then it's S100 or SOX10 negative, the short list of differentials, I think of spindle cell lipoma, perineurioma, DFSP, and low-grade fibromyxoid sarcoma, because all of those have kind of a neural look, but are S100 negative.
Great, brilliant, very nice case. I really enjoyed it. That's very pretty and
Yeah, it's beautiful, right?
yeah, old-fashioned Dermpath morphology.
Old-fashioned, that's right.
Case number 5. I'm really looking forward to this one. Adult man with rapidly growing edematous painful nodule on dorsal hand. So here you have to lead me a little bit.
All right. Well, we can do the low power, you know, we can piece together
Yes.
what we're seeing. And I think that there are some low power clues here that help us get to the
So a lot of
diagnosis.
epidermal pseudoepitheliomatous epidermal hyperplasia looks like.
Yeah, dramatic, right?
Dramatic. And then there's some kind of vascular component and
Right.
inflammatory component.
And tons of edema, right?
A
The
lot of
papillary
edema.
dermis is just so loose with edema in the background wherever there's not vessels. So I'm really curious to see if anyone can get this from what you're showing them here. Because I think it'd be fair to have several things in the differential. And I would have several things in the differential if, you know, seeing a case like this. This case, I don't get the credit for diagnosing. It had been diagnosed prior to me. It's from a long, long time ago, but someone gave me the recut of it, and then I found out the history. So it's just a lovely example, though, of something that I don't see very often. Oh, there, perfect. You found the area. Good job, Artur. It's not your first rodeo.
Well, it's more a matter of luck.
Yeah.
Yeah, so here I think what you are referring to is the squamous lesions, you know, how do they look? The cytology. Is there anything abnormal there? There's kind of a smudgy nuclei, I guess. That's the key here, perhaps, right?
And then there's some little, well, I don't want to give it away. I want to see
Yeah.
if anyone knows what it is here. So you probably can run your mentee voting.
Yeah, let's do it. Let's do it. Yeah, so what is your diagnosis on the mentee? I'll keep showing this around. Okay, so let's see, give it 10 more seconds. Ooh.
Wow.
Hmm. Okay.
Ooh, orphan Kaposi. That's a cool idea. I like that.
Orphan
Fascinating.
Kaposi.
There's some
Yeah, I
great
mean, why
ideas.
not? You know, those
Why
can,
not,
I mean,
right?
during HIV epidemics, that would be very likely vascular angiomatosis and yeah. So you see here you can really appreciate the quality, exceptional quality of the Dermpath audience.
Yeah, good job, guys. Wow.
Your diagnosis ORF. I thought it was a fascinating. When I saw this case, I said, gosh, um, it's kind of amazing to make this diagnosis.
So the nice thing about ORF is if you think of it, then usually you can get some history that will end up really helping a lot, right? Because ORF is
Mhm.
a pox virus that's contracted from goats and sheep, right? And it's actually relatively common in animals. And it goes by the name scabby mouth. So most people that raise goats and sheep are like farmers are pretty familiar with this. And even though I rarely see this biopsied in my practice, I've only seen a few cases in my career. There have been studies that looked at areas where there are lots of goat and sheep farming. I think maybe one of the studies from Australia or New Zealand, where when they surveyed farmers, like about 25% of them had reported that they had had lesions that were consistent with ORF. They recognize what it is and they didn't go to the doctor. They know it'll get better in a couple of weeks and it'll be fine. So the ORF is a little challenging because it is a process. There's a virus that has different stages, right? So as it progresses, it gets more and more edematous. Then you get this massive expansion of the papillary dermis. The rete get really elongated and very, very thin. So that is the one thing here. It looks like pseudoepitheliomatous hyperplasia, but you can see some areas the rete are like extremely narrow, which is a little weird because usually when we see reactive pseudoepitheliomatous hyperplasia, it's kind of expanded, dilated, and there's some of that here, but there's also these really thin, delicate kind of stretched down rete. And then as the process progresses, it begins to develop this brisk, robust, reactive vascular component under it. And then when it gets like that, it can mimic a vascular lesion like Kaposi or vascular angiomatosis or pyogenic granuloma, lobular capillary hemangioma, even though admittedly it's not as lobular and usually you don't see so much edema in a PG, but I think it'd be very reasonable to think of any of those things. And then the classic thing you're supposed to find is in the epidermis, in the keratinocytes, you should see these little red or pink eosinophilic inclusions that are supposedly viral inclusions. So there are some, pink blobs there, but I don't know, like if you go up just a little bit, Artur, just from where you are, towards the top of your screen, if you just scroll like just a few keratinocytes higher, or not that much.
Mm.
That same area you were at, just a couple keratinocytes up there, some little globules. The problem is I see lots of little eosinophilic globules in tissue, especially when there's blood, when there's serum. So right at the bottom left corner of your slide, there's a little dot, a little pink dot in a keratinocyte in the actual like spinous layer down below the serum. If you zoom in a little bit, like right in there, there's a couple dots. So there you go. That little pink dot just below your arrow. Is that an ORF inclusion? I don't know. I'm not 100% convinced because there's some little tiny, tiny dots next to it. So I have to tell you, that's the test answer, guys. But in real life, I find these challenging to recognize. I mean, I can always find a little pink blob if I want, but am I really convinced that's a viral inclusion? No, I'm not. So maybe better people than me can do it. But what I like better is if I think about ORF and then I find out, oh, the patient recently had goat or sheep exposure, and we know that this makes sense, then great. I saw a case a while back that we were pretty sure was ORF, but it had tons of neutrophils in it and looked almost like sweets clinically and microscopically, but had tons of edema and long, thin rete. But it was on the scalp of a little kid. And it turned out the little kid had been to a goat farm, to a goat petting area just a couple weeks previously, and his head height was about the height of a goat's mouth. And so goats love to chew on everything, including hair. So we postulated that. We're still working on getting it published. The journals are like, well, we really want EM, so we're going to try to pull the case and see if we can run EM to prove that there's virus there. We found in that process, we searched a lot of labs, and no labs do molecular that we could find for ORF in the United States on patient samples. Some animal labs will do it, but so we really thought, oh, this should be easy, but we couldn't find anyone. So if anyone out there knows how I can get a viral or IHC testing. We even checked with the CDC. They have a stain, but they said they cannot do it on a CLIA a human patient sample unless it's a pure research sample. So to our sadness, we couldn't get it there. So if anyone else out there knows, I'd love to hear from you so we can prove our cases or our other cases or with neutrophils. But pretty cool, and something we don't see often. I see Dr. Tyler's on here. He was a colleague here with me in Danville. And then he retired around just a bit after I started. And he said that sometimes we would see cases in Pennsylvania after the Bloomsburg Fair, which is the town I live in. And it's a huge, huge fair that's going to happen in, I think tomorrow is the first day it opens because they have animals there, lots and lots of animals. So sometimes occasional cases will pop up after the fair because of increased exposure to goats and sheep. So there you go.
Yeah,
That
wonderful.
patient actually also, I remember he was a transplant patient and he had cut himself while slaughtering a goat with a halal goat slaughtering for a festival. And he accidentally cut himself with the knife that had the goat blood on it. And then he developed ORF later. And his case was pretty severe because he was immune suppressed. And they ended up, I think they gave him like antiviral therapy and it finally went away. But he had a much more robust case than usual because he was immune suppressed, or that's what we theorized. It was long ago. I don't remember all the details.
Yeah, great, really great case. I was just trying to find a case on Dermpedia, and because I had a consult that I shared, so you can go and find it if you search for ORF. There are cases there too. Yeah, wonderful. I think that really expanded my differential diagnosis because I wasn't really I wasn't that familiar with that pseudoepitheliomatous hyperplasia.
Oh, it's so extreme, right? And the
So
vascular part too. When I saw this case
yes,
first, I didn't conceptually know that they
because
could be.
that must be the late stage. The
I
virus
think
is almost
so.
gone. There's
Yep.
just kind of a residual process.
Yeah.
So case number 6, and you
Ugh.
have an 80-year-old man with a papule on the nose, and a case that taught you a very important lesson.
Very important lesson.
Yes, very important lesson. I wonder what that might be. And let's take a look at the H&E in this case. So we're going to do the H&E, and we're going to share with you the immunohistochemistry. Very busy. Pleomorphic spindle cell neoplasm, yes.
Yep. Ugly cells filling the dermis in old sun-damaged face skin.
Right.
Sorry for the folds. There's that case from a long time ago. I didn't have a way to make new slides, but it'll have to be good enough.
That really testifies to the authenticity.
That's right.
You never want to, improve on nature. Really, yeah. So that's the, I think, histology. And let me share with you the immunohistochemistry. The tumor cells were negative for SOX10, S100, pancytokeratin, P50, P63, desmin, and CD34. And the question for you now is, what is your diagnosis? And we'll ask that question, I think, again. There are some clues to that diagnosis, maybe on the H&E, but
They are subtle though.
they're
Very
subtle. So I give you 20 seconds on the Mentimeter.
True fans know this case. Someone has been following because I have posted this case quite a few times before, actually.
No,
I should have thought of that. I should have known
come on.
that.
This is Dermpedia. This is the most advanced group of dermatopathologists
Guys are
on
good.
this planet.
It's awesome.
These are not students. I
Very
didn't
good,
expect
guys.
anything else. Angiosarcoma is the diagnosis.
I think this is a case that could
From
trick
Dermpedia
anyone.
audience.
Though. I'm so
And
proud of
what
you.
would you do next? And you shared the immunos, CD34.
Yeah, just in case you didn't believe me, CD34 is negative. It is negative, like
Right.
totally negative. You can see background vessels that are positive. There's your DFSP control up there. And here, the background vessel's positive. The tumor cells are completely negative for CD34.
Okay.
But
ERG,
you don't even need a microscope, right? Blazing positive.
CD34.
Or 31.
Sorry, CD31.
Yeah. And you can see I love to write on my slides with markers, and sometimes I forget to wipe it off. So you can always tell in my department if a case is mine. If it's got blue marker or purple marker, I'll always slide it's my case.
So
Yeah,
spindle cell angiosarcoma mimicking AFX, but how popular was the diagnosis of AFX?
it was on there, but smaller.
It's on there. Yeah, yeah. Because I think that lesion, actually, that H&E, those holes, those little
Yes, good.
vacuoles, right?
So I think there's a few clues.
Signets.
The little vacuoles, endothelial tumors, particularly angiosarc, epithelial hemangioendothelioma, they tend to make little vacuoles sometimes. Kind of like in EHE, they're called blister cells, right? But we can see similar kind of vacuoles in angiosarcoma and sometimes in other things like epithelioid hemangioma, ALHE. They make little vacuoles. They don't look like this, but they make vacuoles. So the other thing is you can see this kind of like nested area at the top. That's probably a vascular channel that has completely been filled with tumor cells. That area with the crack over at the right there, but just below the epidermis. It's kind of this long kind of serpiginous structure. That was probably a vascular channel formed by tumor that then filled up. So my partner, Jackie Junkins Hopkins, here at Geisinger, she likes to say it's that the angiosarcoma, the endothelial cells are like fish in a creek. They're like swimming and filling up the middle of the creek. And I think that's true. And sometimes they get so full that they completely overrun the center of the creek, the lumen of the spaces, and they become solid. If you have a big enough sample, these solid angiosarcomas usually will have areas of obvious vasoformation. But on a small shave, you sometimes don't get any of it. So you have to have a high index of suspicion. So the other thing is the blue-gray, kind of this slate gray-blue color, amphiphilic cytoplasm. Angiosarcomas, especially the more epithelioid ones, the more cellular solid ones, they tend to get this bluish-gray look to them. And in a way that you don't see as often in say, AFX or other entities. So that kind of bluish-gray or amphiphilic quality. And also the cells are kind of plump and epithelioid. Can you have epithelioid atypical fibrous xanthoma or pleomorphic dermal sarcoma? Sure you can. Is it common? No, not in my experience. Anytime I see something that I think is an AFX or PDS spectrum, but is pretty epithelioid, I'm always extra cautious to make sure I've excluded all the other stuff, because I've seen a variety of times where things that looked like AFX but were more epithelioid ended up being angiosarcoma, epithelioid rhabdomyosarcoma, and other stuff. And these are things that are much more aggressive. Angiosarcoma is a very aggressive malignancy, much more concerning than AFX or PDS. So if you look back on the CD31, Arthur, I think you can actually see some vasoformation. One of the stains shows it. I think it's the CD31. It just wasn't really obvious at all on the H&E, but on one of the immunostains, that deeper cut showed a little area where there's an obvious vascular channel. Let me see if I can find the area on the slide here. I think it's 31 that had it. So the lesson I learned from this case is angiosarcomas can be CD30. Yeah, look at the right there. On the right side, you can see that what looked solid as you go over to the right edge of the shave opens up, and it's a vascular lumen now, lined by multi-layered atypical endothelial cells right there. So again, maybe even just deeper H&E cuts would have made this obvious. But this was the story behind the case is it's a long time ago. A colleague, a friend of mine, sent this case to me and said, I think it's probably AFX, but something's kind of weird about it. And he had already done the CD34 and that whole panel of stains, and still was like, I still feel like it's a little weird. There's a little vasoformation at the very, very edge there, probably, or discohesion at least, So I saw it and I felt the same thing. I was like, maybe it's an AFX, but it's kind of weird. And I thought a bit about angiosarcoma, and even though 34 was negative, I added ERG and CD31, both of which were blazing positive. And so the part of the reason I was able to get this was a story shared by and said that he had mistaken angiosarcoma once and thought it was an AFX, and it was one of the biggest mistakes he had made. And I thought that was such a brave thing to like openly share that with the audience. And thank God he did, because I thought better soft tissue pathologist and Dermpath than I'll ever be. And if he could make that mistake, then I sure as heck could make that mistake. And it was, this case came in about like 6 or 8 months later. And it was because of that memory and that fear of thinking, oh my gosh, that's scary. So because of him saying he always, wants to keep that in the differential and not mistake an angiosarc that was solid as an AFX. So I started adding a vascular marker on my routine panel, which I had not done originally at the very early stage of my career. And it was, and because I knew that CD34 sometimes is negative in angiosarc, and this one worried me enough, I added the ERG and the 31 and it proved the diagnosis. So now my routine AFX PDS panel, I pretty much always include either CD31 or ERG. ERG is my go-to. Just so you know, the ERG is very sensitive, but it's not specific. It can stain AML, acute myeloid leukemia, stains prostate cancer, which of course is extremely rare in the skin, stains about 50% epithelioid sarcomas and other stuff. But it is very sensitive and super strong in angiosarc, and it should look like the case we just showed you here. Anything patchy or weak or like staining some of the cells and not other, not angiosarcoma, okay? And AFX often has some patchy ERG staining, you can just ignore that. Don't worry about it. It should look like 4+ positive, 100% of the cells, as strong as the background vessels. That's the way ERG stains vascular tumors. If you have to ask yourself, is there enough ERG here? The answer is no, probably not. It's probably not vascular if you're questioning that. Usually you just look at the slide with your naked eye and you're like, whoa, ERG is positive. So anyway, there's a great case about like the benefit of sharing mistakes we've made and challenges we've struggled with, because our trainees can learn from that. It's a great example of having awareness that angiosarc can be solid and can be spindly sometimes and can mimic other sarcomas when that happens. And usually it's on a small shave like this is when the big problem happens. Usually, again, you'll find vessels if you look around enough or get a deeper, bigger sample, but you don't always get that up front. Sometimes angiosarcs don't have any violaceous color clinically. Sometimes they don't have any blood-filled spaces microscopically. I've seen multiple cases. I've also seen Kaposi that way, where there's no blood at all. And when you don't have any blood-filled spaces, it's real easy to not think of a vascular tumor. So this whole theme of the session has been vascular tumors that look like they're not, and non-vascular tumors that look like they're vascular, right? And I think that's a good thing, is that we can get confused either way. So again, I'm a big plug for either ERG or CD31, and I would recommend against using CD34 as a screening marker for vascular tumors. It's often positive in angiosarcoma. I would say even usually, but I've seen many examples now of angiosarc that were partially or completely CD34 negative. So do not trust CD34 alone for ruling out angiosarcoma, okay? My AFX PDS panel personally, and everyone's got a little different view. I like to do a high molecular weight keratin. In my lab, I think CK56 works best. Some people like CK903. Some people like pan keratin. That's fine. I feel like in my lab, CK56 works better than pan. I also like to use a nuclear marker like P63 or P40. P40 is what I currently use because it's cleaner. If you don't have that and you only have P63, that's fine. I know some very good dermatopathologists that don't like P40 or P63 because it's kind of a little wishy-washy, and that's okay if you don't want to use that. And then I usually use a SOX10 as my melanocytic marker to rule out. I know some people who like to use more than one melanocyte marker. That's okay if that's what you want to do. And then I usually use a Desmond to rule out rhabdomyosarcoma, which is really rare in the skin, but it does happen, and it's very bad and aggressive when it does. And then also leiomyosarcoma, which is part of the so-called SLAM differential. But I'll tell you honestly, I don't think I've ever seen a case of actual leiomyosarcoma in the dermis that at all confused me for AFX or a spindled squame or a spindled melanoma. Leiomyosarcomas in the skin look like leiomyosarcoma, and they're usually on the trunk or maybe the extremities, not on the face of old people. At least, I don't know, Arthur, have you seen very many leiomyosarcomas on the face of older people? I think I've seen one
not
on
really,
the scalp.
but I've seen ERK positive in some areas, not diffuse positive AFX. So and I
sure.
I shared a few examples actually on Dermpedia in my consult session, so you can just ERG. If you search, you'll find, I think, one or two.
Yeah, it's almost like a feature. Like it's more like a lot of tumors are cleanly negative for ERG, but AFX often has patchy staining.
Yeah,
and as long as you know that patchy is okay, don't worry about
it.
it.
And D240 can be often positive also in squame. So one has to be always, but I have to tell you, in this case, my differential diagnosis would also include a hemangioendothelioma.
As it backwards, yeah.
because there's certain kind of uniformity of, again, the cellularity, and I would wonder, um, if that lesion could also, I mean, that's certainly in a differential diagnosis, that one of those fusion
Like an
driven,
epithelioid hemangiothelioma.
yeah,
Like they usually are more kind of
or
nested and cord-like, but
rearranged,
oh
uh,
yeah,
yeah, just a fusion, because there's certain
yeah,
monotony. Like I usually
there
think
is.
of angiosarcomas as being very pleomorphic, more pleomorphic than this case, and so just something to consider, to expand the differential diagnosis, in a vascular tumor that
Yeah. And
looks
so
like
if you're
less.
thinking about that for the audience, that would be a good time to do like an NGS fusion panel
Right,
to make sure that you look for the WWTR1
right.
CAMTA1, YAP1 TFE3, and others. And so I think that's a good thing to think of. And there is a big difference because angiosarcomas are quite aggressive. They get really aggressive treatment and have a very guarded prognosis. I've met people that are I volunteer in an angiosarcoma patient support group on Facebook. I've been doing that for over a decade now. So I've met some long-term survivors from angiosarcoma, which is amazing. But I've also met a lot of people who died and family members of people who died quickly from angiosarcoma. It's a horrible, horrible tumor and very serious and much more serious and aggressive than most of the other things in the differential. So it's really important to always keep it in mind. And hemangioendothelioma is depending on which type are sometimes they can metastasize the epithelioid one, but the other ones are more like locally aggressive, not as often metastasizing. So they are not as aggressive of a disease as angiosarcoma. So important to make that distinction. Great point.
I think we exhausted our time. Uh, we exceeded this hour, but as you know, we're not really on any time schedule during the
Everyone who
workshops.
watches any of my videos knows that I always go over time on everything. So they're probably used to this.
Yeah. Okay, so thank you very much. Let's see if there are any final questions on chat. If
Someone asked about can PRAME become positive in pleomorphic dermal sarcoma? I don't know. I don't usually use PRAME unless I'm trying to figure out if something's melanoma versus nevus. So I've not really applied it. I know that like dedifferentiated melanomas, which are rare but do happen, they usually are diffusely PRAME positive. And so that is a question that comes up, but I've not tried PRAME on enough cases of like AFX PDS to know like how reliably negative. I think there was a paper last year by Jason Hornick and colleagues from Brigham and Women's about using PRAME on D-diff melanomas. And they did, I think, look at some AFX and pleomorphic dermal sarcoma, but I've been a little hesitant to include it in my panel because I just don't have enough experience to know, like, what will I do if I've got some patchy PRAME positive or even diffuse positive and everything else melanocytic is dead negative. Because raising like, oh, this is AFX PDS, but maybe could be D-diff melanoma. I mean, like it's a pretty big difference you're bringing up there. And so I've been a little hesitant about that, but I think that's a great question. And
yeah.
and I don't know. Do you use PRAME in your panel of
No,
AFX?
but any time there's a possibility that the lesion could be melanoma, I think a lot of effort has to be spent
Yeah,
to confirm that. And probably now the best way to go about it is just to do NGS, look for
yeah.
melanoma, signatures because of the treatment. If it's melanoma now, melanoma is a good news. Yeah,
They got
paradoxically,
options, right? Yeah.
it's a good news because there are good treatment options. So, Jared, thank you so much. Thank you
You are. Thank you.
for
It's really great.
doing this, workshop and
It was
really
fun.
showing
And thank you
your
everyone for showing up. This was really, really great.
incredible ability to describe things. You use at least 10 times more words that I can really come up with
I have
for
I have
a
probably
single
spoken
case.
several
But
lifetimes
you
worth of
use
words
them
already.
very well. It's
Thank you.
it's fun to
I've
watch.
been talking a lot since I was a little child, and I've never stopped since.
Yes,
So it's just
yes,
the way I
yes, and you
am.
and you find a niche that allows
I
that and
do.
actually creates an audience of people who are very grateful for your efforts.
Thank you.
And so am I, and so is the audience of today's workshop.
Awesome. My
I
pleasure.
hope
This was
to,
really fun.
see more of you. And actually, guys, there are those little hearts that you can see. Just if you like this idea, how about putting Gerald on my short list of folks who could take over Dermpedia when I retire? How about that? Is this a good idea? Look at the hearts.
That hearts.
Yes.
Thank
Okay.
you.
He
Very
is on the
kind,
short
everyone.
list. So, okay, folks. Thank you so much. Thank you, everybody. Thank you.
Have a great day, everyone.
Bye.